Now the hip cross pattern is very complicated, and very few people talk about the cross pattern, but the questions are actually about it. They just don't say they're talking about it because it's just kind of weird. But this is, the green up here is the QL, the quadratus lumborum. You should think about that with scoliosis. It hooks to the iliac crest and goes up to those lumbars, okay? So it's gonna crank in and cause that scoliosis problem. So we would want to stretch this one and of course strengthen the other side. That's the key to most of the scoliosis exercises. Now when we talk about glute med and TFL, I want you to realize the glute med that we talk about is real little like that, right? But the TFL crosses two joints. So when you cross two joints, let's just look at that TFL, one of the things you're going to get when you kind of pull that really taut is you're going to start to get coxa varus and genu valgus. So look at that, you've immediately caused an altered kinetic chain in two joints. You're probably going to end up with trochanteric bursitis and lead to adhesive capsulitis and all kinds of problems. So this is probably one of the more complicated kinetic chains that we don't talk a lot about, but they're starting to ask more and more questions about as kind of people really get a clear picture of it. So realize then with the glute med, it's a glute med weakness. So we've got to build this glute med up. Now, the way we build that glute med up is we stand on the other side and do the hip hiking. Okay, the way we take care of this one is we've got to stretch it because this is not a weakness, this is a contracture. So the TFL is a contracture, the glute med is a weakness. Now the thing about glute meds is you can go ahead and strengthen this side and you can weaken that side, but you don't dare do that kind of stuff with this one because it's crossed two joints and you'll end up making one part of it worse and one part of it better. So what we always do is just try to release this. We stretch this, we trigger point it, we just focus all of our attention on the TFL and we take care of it. Now the other problem that we have sometimes involving the hip is the psoas. So it plays a role when we talk about hip flexion. So it plays a role in the cross pattern of the lumbars and part of your core, and it plays a role in the hip. So it is a pretty important animal. So I want to talk to you about the psoas contracture hurdler stretch, which is a very difficult thing to do, but I want to pause and get the table ready to show you that. Just an honorable mention, the adductors then are the midline creatures there, and I don't really bring them up. We don't talk about them too much, but at least we've mentioned them. So that if this is weak, those are probably very strong. And the opposite would be true with the TFL contracture. So we usually just don't strengthen the adductors. Okay, now, when we talk about the hurdler stretch, back when I was in school, high school, I suppose you can tell that was a few years back, okay, the hurdler stretch was when the person kind of reached forward like this as if they were going over a hurdle. But now you have the person lay back and try to pull this leg back, and that's supposed to try to stretch that psoas. So the hurdler stretch is for the psoas stretch. I'll tell you, most people can't do that. But you can take somebody like this, lift their leg back like that, and try to stretch the psoas, or have them stand on the table and lift their leg up. Usually massage therapists do it in that way. But anyway, hurdler stretch, psoas. Now as we talk about number 2, the Q angle is what lines up the hip, the patella, and your foot so that we know if this is all straight and appropriate, or have you got coxa varus, genu valgus, that kind of thing. So I've just put a love note down there about the Q angle so at least you know what they're talking about, and at least you know it's hip. Now when we look at gluteus med, the glute med weakness, this just reminds you of some of the key ways to focus on that. So it could be the side bridge, and you could be, swaying your hips. It could be the one-legged stance where you're kind of hip hiking. It could be the clam where you're opening up your leg while you're lying down. So all of those would be considered gluteus medius friendly. Now the TFL, remember, sideline stretch. Now let's bring this up. I want to show them a couple of things here. Okay, the sideline stretch and trigger points is probably the best way to approach it. When I say combo therapy, remember, let's go back to passive modality for a minute. That was ice and something else because we're breaking up trigger points. Remember, trigger points. So this is kind of a myofascial problem. So I want you to think of that way. So let's write this down if you haven't written it down. Coxa varus and genu valgus. Remember, that's what I showed you when we tighten that TFL string. So we'll get coxa varus and genu valgus. Coxa varus, genu valgus. Now when we move to the QL, and I've circled this for you on your pages, if you can bring that up just a tad for me. Okay, a scoliosis. Now let's picture that our person has, they're facing like this, right? So they've got this scoliosis. So what we've done is we've put the convexity up and we're trying to get them to sink it down. So that would be a side plank. We're trying to get them to kind of sink it in there. When we are stretching it, we want to put the convexity down and pull them over it. So those are both side planks. This is obviously more stable. This is a little less stable. Okay, so our person has to be advanced and ready for that. But that's the language of QL. All right, we've turned the page and we're talking about the knee. Most of us know the vastus medialis is the, well, supraspinatus is to the shoulder, what vastus medialis is to the knee. Who's the first to break down? Who do we have to rehab? Who's the hardest to rehab? You know, who takes the longest to recover? Vastus medialis, supraspinatus, kind of one for the shoulder, one for the knee. When we're talking about that particular event, there is an exercise where you put the CHOPAT, the COPAT brace on it, and then you have the person extend with their leg externally rotated. And it's those last 30 degrees that really kind of focus on getting the knee rehab. But this just talks about the fact that the ACL has very little blood supply. We should know that. So if it's unstable at all, I'm sorry, it's attached to the blood supply. I said meniscus has very little blood supply. Let's go back to that. The ACL is attached to the blood supply. So if it's unstable at all, you can't be just in the knee because you'll tear it, you'll rupture it, they'll bleed out. The meniscus has very little blood supply, so there's little pain with it except when it tears and folds, and then when it locks the joint, it's very painful. So it's all about the disruption in the joint mechanics, and flexion is usually pretty friendly, but when they go to extend, they can't extend it because that piece that's pinched is really angry. Now the PCL, the language of PCL is sag side. Okay, sag side is PCL all day long. What it really amounts to is that if this is the femur and this is the tibia, it has dropped down, so it's weak. So it doesn't matter if we're looking at it this way, it doesn't matter if they're laying up and looking, it doesn't matter if they bent their knee, it will be sagging. So the sag sign is PCL information. Now these three for the calf. Let's take a look at these. After trauma, could you tell if somebody had compartment syndrome or if they just had shin splints? So we got to be able to do that. With DVTs, what's our number one concern? Pain in that posterior calf. Some kind of stroke, right? A traveling clot, a thrombophlebitis. Say it could even go up into the heart. So we're worried about that clot travel. Intermittent claudication. There's neurogenic and there's vascular. Neurogenic we can manage. Vascular we should be co-managing. So these are all situations that we've kind of got to talk about. So let's take each one, kind of tease it apart, and make sure that you can tell the difference. Now, a lot of you think that the shin is just on the front, and you're right, except that when we talk about shin splints, okay, or shin pain, they can be in any compartment. They can be on the anteromedial, the anterolateral, the posterior medial, the posterolateral. So anywhere around your whole calf, you can have pain. So if that's true, your whole calf can have pain, then it isn't so much where the pain is as to the rest of the story. So activity or some trauma can bring on some pain in your calf, and it might swell up and get a little red. That's still shin splints. But if we start to talk about the fact that we can't feel our foot, we can't feel our toes, we can't curl our toes up, then that's compartment syndrome. So I want you to realize that compartment syndrome is not just the pain and redness and swelling, it's the neurovascular entrapment signs. So compartment syndrome is called neurovascular entrapment. Okay, and it's limb threatening, it has to go right to the hospital. Now we talk DVTs, that's pain behind the calf, and if we touch that and kind of push up on it, a key question is to say, hey, have you been active lately, or have you been sitting on a plane for a long time, sitting in a car for a long time? Because that inactivity can lead to clotting. So we want to find that out about the person, or find out if they're on some kind of drug therapy that could be leading to this, like the hormone therapy, the estrogen, the birth control pills. If so, we've got to get that right out, and it should be ultrasound. They should read it, find out if it's deep, superficial, what the odds are, and take care of the patient. But they should be laying low and not moving a lot. Intermittent claudication. Claudication is pain. Intermittent means it comes and goes. So here's the full story. You walk. You say, ow, 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 my calves hurt, oh, my legs hurt. You say, stop. Oh, I feel better. That's intermittent claudication. So you walk, hurts, stop, better. Okay, so it's pain aggravated by activity and relieved by rest. So is it vascular or is it neurogenic? Becomes a very important question. Do we manage the case or do we have to co-manage? So here's the deal. If you're talking about the fact that it is immediate relief when you flex, now I don't mean you have to stop, you have to keep going. Okay, so I'm walking along, ow, 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 flex forward. Oh, hey, I can still walk, this is good, I could go forever. That's neurogenic because you don't have less diabetes, less burgers, less arteriosclerosis when you bend forward, but you open up the canal. So the whole idea is to have the person in the stoop position and see if that can relieve the activity. So they would go pretty far on a bicycle, but not so far, not do so good going upstairs, because going upstairs would put them in a what position? Extension. They're relieved by what? Flexion. So if you can keep that in mind, here's the whole secret to neurogenic and vascular, is that neurogenic can go further in flexion. Now look at this. Vascular is always a predictable amount of steps. In other words, it won't be whether you're going upstairs or downstairs. It'll always be 120 stairs or 19 stairs, whatever the stairs are. Okay, so that's the deal. This is predictable, and this is relieved by flexion. Okay, but realize this. Both of these patients have to walk. One we're just co-managing, one we're managing all by ourselves. But intermittent claudication is usually treated by walking, and it is canal stenosis. It's central canal stenosis. I just was polite and put a few things in about the feet. So far there haven't been too many feet questions, but you've got the transverse arch, and you've got the keystone is the second metatarsal, so it drops a lot. It usually causes the havoc. It fractures the most. So the second metatarsal builds up most of the issues with the transverse arch. The longitudinal arch, the medial is the navicular, and the lateral is the cuboid. If you think about this, what are the most adjusted bones in the foot? The second metatarsal, the navicular, and the cuboid, because they're the keystone. So that makes a lot of sense. Finally, we have the neck, and when we talk about the neck, we've got torticollis. Now, I always teach in part 2 that torticollis, if you put your hand on your sternum and you put your thumb up here, or reverse it, whichever works for you, but kind of put your thumb on your mastoid process or your finger, whichever works, and your thumb down here in your sternoclavicular. So figure out which works for you, and then try to contract that or make them closer, approximate them, and you'll see you'll laterally flex that way, but you'll rotate the opposite direction, and that's a torticollis spasm. See, if it's the splenius capitis, it'll be same rotation, same side flexion, same, as opposed to same opposite for torticollis. If the extensors are involved, which is AKA the traps, then you will have, with the upper traps and the lower traps, some amount of rotation and certainly lateral flexion, but you'll also have the extension. So the extension tells you it's traps. If you've rotated to the same side as splenius capitis, so keep this little tool in mind to remember what is SCM torticollis. When we're talking about the Sphinx is where the person is on the floor with their hands resting like this and they're kind of jutting their head back and forth like that. It's a retraction, protraction kind of exercise. So it's a pretty good one if a client can get all the way to the floor. You could do it with their hands on the table and kind of practice it. SCM stretching would be for the torticollis. The nodding exercises, okay, is this kind of thing. A lot of us will do that kind of figure 8 sort of nodding with a person with SOT therapy, so we even move that into physiological and paraphysiological joint space. And this is almost always on your test. This is the upper cross. The thing about the upper cross is it's really not complicated. It's just a matter of memorizing it. And I'm sorry, that's just what you have to do. You have to know that these are typically weak as we age or after injuries, and these get tighter and tighter because of the phasic tonic muscle relationships inside of us. We have some that just absolutely have to be exercised to build up tone, and others are tighter almost all the time because of that balance of standing upright. So we usually have to work on building these muscles back up and stretching these as much as we can. And at the bottom of the book here, I put where and this is all relative to the cross pattern here, where are the painful joints where you can kind of push and they'll really yell. So they'll even yell out here at their glenohumeral, their upper traps will be real sore. The trigger points is a pretty common question, and they like you to know this TMJ. It really does get involved with the aging process, postural paresis, this protraction of the head. One of the things to remember, Dr. Laura, bring this back down in case you're confused about it, is that this is not about hyper and hypolordosis. Okay, the upper cross is about anterior head carriage. It's about protraction, and the best exercises are to retract it. That's why the Sphinx works so good. Okay, so realize though, as this occurs then, they can get TMJ problems. It is the lateral pterygoids that are usually affected, not the medial, and then the rest of that is just for your viewing pleasure. Now, for your test, they are going to put at the back of the test a couple of what we call scenario or sequence questions. We do a lot of practice for that for part 3, and that's why I like 3 and PT to be taken together. So we're going to practice a couple of those and some multiple choice.